We're probably more international than most of the other, quote, international schools. So about 30% of our students are not U.S. citizens. We train a fair number of Canadians, people from Europe, Asia, Africa, all over the Caribbean basin. We not only have, 15 Grenadians, but we probably have an equal number of Trinidadians and others. So no, we're truly an international school, and those students often don't train in the United States. They can train in England, they can train in other countries. So we're a fairly international school. We still have about 70% of our students from the United States, and I would say most of them want to return to the United States and train in residency programs. And so we design our programs to help our students succeed no matter what their professional goals are. I think all of us contribute to solving the doctor shortage, but the doctor shortage per se is not, in my opinion, our number one problem. A far greater problem is the maldistribution of doctors geographically and the maldistribution of doctors by specialty. So I would argue that in addition to just building another medical school, we should design the newer schools to try to do a better job of addressing our country's healthcare needs. Now, I think it's a problem if only a third of the graduates of U.S. medical schools go into fields like primary care that we actually need. So the shortage in primary care doctors is considerably greater than, let's say, the shortage of plastic surgeons, if there even is a shortage of plastic surgeons. So we have to design the schools to do, I think, a better job of delivering that social need. I'll also say who gets into medical school we ought to take a harder look at, because about half the decision of where doctors practice is where they come from, and about half the decision of where they practice comes from where they do their residencies. And today, the real choke on the supply of physicians is not at the medical school level, it's actually at the residency level. And we need to distribute those residencies because they're so impactful on where doctors practice to areas of the United States that have the most severe physician shortages. And those new residency programs should not be in already high supply specialties. They ought to be in the primary care specialties and some other specialties like psychiatry, in certain areas of the United States, OB, clearly general surgery. There are other areas for which we have a national shortage besides primary care, and we should be focusing more on training more doctors that our country needs. I think most new medical schools in the United States are just following exactly the same template as every other U.S. medical school in the United States, and I think that's a lost opportunity. I'd like to see them do a better job of addressing those needs. The other thing about building new medical schools is who gets into medical schools. If you read the IOM report, the Institute of Medical Education, I was actually surprised and a bit dismayed by the fact that 80% of the medical students in the United States today come from the top 2/5 of economic background. Basically, we're training the sons and daughters of wealthy Americans and then wonder why we're having trouble getting those doctors to practice in underserved areas, take care of Medicaid patients, go to urban poor areas and rural areas of the United States. We should be rethinking who gets into medical school. It's not about taking unqualified candidates, it's taking qualified candidates that come from rural areas of the United States. It's taking candidates that come from lower social and economic groups because they're much more likely to return and take care of those populations. We've got to do a better job as a nation, and that's both international schools and domestic U.S. schools, in selecting physicians and designing education for our country's social needs. Internal medicine, family medicine, psychiatry are all common specialties that our students go into. I already mentioned that 3/4 of them go into primary care, so they are in large numbers going into primary care specialties, but we also train a fair number of general surgeons and obstetricians, and those are, although specialties that are not primary care, those are still specialties that are in high need. You can identify what fields they are because just take a look at the national match we just completed. Basically half the family medicine residents, half the internal medicine residents are international graduates, and so obviously we're going into a lot of those fields. On the other hand, if you look at dermatology, neurosurgery, plastic surgery, vascular surgery, those are virtually all U.S. graduates going into those fields. I think the more immediate job I had was as the founding dean at the University of California, Riverside. I had a rare opportunity to build a medical school around the social needs of a particular geographic area, inland Southern California. That's an area that has very rapidly growing. It's the third fastest growing area in America. It has a huge physician shortage and a particularly huge shortage of primary care physicians. It scores in the bottom quartile in virtually every measurable outcome in the state of California. And it was a unique opportunity to kind of rethink what we're doing in medical education. And that, I believe, is a medical school that was designed to actually address the societal and healthcare needs of that community. I thought that was a wonderful thing to do. I'm very proud of that university. But the opportunity at St. George, as I looked at the job, was to do the same thing but on a national scale. Could we be the medical school for areas of the United States that don't have medical schools, that have shortages of physicians? Could we partner with local community hospitals? Could we recruit students from those same geographic areas so that the plan might be, I'll recruit some students from rural Colorado and I will bring them to Grenada for 2 years and I'll return them to community hospitals in those same areas for the 3rd and 4th year rotations, and we'll help them develop family medicine and general internal medicine and general surgery residencies that they can go into. And by doing that, I would be doing exactly what I did at University of California, Riverside, but for many areas of the United States where our physician shortages are most acute. One of the things that I knew before I took the job is I knew St. George had really excellent graduates because I trained many of them. I trained them at Brown, I trained them at Case Western Reserve, I trained them at the Medical College of Wisconsin, I trained them in California. So I knew they had really good graduates. But I did not appreciate until I got here that they trained such outstanding physicians with such a focus on the success of each and every one. And I think that that's truly the remarkable and very distinguishing feature of the university.